This is Stanford Engineering's The Future of Everything, and I'm your host, Russ Altman. If you're enjoying the show or if it's helped you in any way, please consider sharing it with friends, family, and colleagues. Word of mouth is one of the best ways to spread news about the future of everything. Today, Tina Sindher will tell us that allergies are on the rise globally. That's bad news. But our ability to prevent, diagnose, and treat them is getting better. So that's good news. It's the future of allergies. Before we get started, a reminder to tell your friends, family, and colleagues about the future of everything. That word of mouth spread is what helps the show grow. So we're all aware of allergies. In general, they come in two types. There's allergies to food. That means you have to worry about exposures to peanuts or seafood or a variety of other things. It means when you go out to dinner or to lunch or to breakfast, you have to make sure that you're not being exposed to the wrong kinds of food. And then there's allergies to the environment, pollen, hay fever, flowers, the forest. People can have very different relationships to both food and to their environment if every time they're exposed, they get itchy eyes, trouble breathing, rashes, eczema. So allergies are a big deal. And one of the parts of that big deal is that they're on the rise. It turns out that climate change, as we will learn, is affecting the rates of allergies. On the other hand, our ability to prevent, diagnose, and treat is also getting better. Tina Sindher is a professor of medicine, pediatrics, and allergy at Stanford University and an expert especially on food allergies, but really all allergies. She's going to tell us that it's a problem, but we're starting to find good solutions. Tina, you're an expert on allergies. Why do allergies happen? And why do so many of us suffer from them?
Oh my gosh, that is a great question. It is something we think about all the time. So when my emphasis is mostly on food allergies, so I'll come at it from that angle, but
Sure.
really that can be extrapolated to any type of allergy. So essentially what happens is that our immune system, when we get exposed to allergens for the first time, our antigen presenting cells take up that antigen, or let's say peanut, and it breaks it up into little proteins and exposes our naive T cells to those proteins or epitopes. And in an environment where there's already a predisposition to allergy, we call this an atopic milieu or a Th2 skewed system, that exposure to the allergen causes our B cell antibodies to produce allergen specific IgE antibodies, which are bound on our mast cells and basophils. So the next time your body recognizes the protein, let's say the child is eating peanut for the first time, or it's the third or fourth time, those allergen specific IgE antibodies recognize the peanut and cause the mast cells and basophils to degranulate, which release the histamine, the leukotrienes, all that inflammatory cells that are associated with an allergic response. And that's what you end up seeing.
Okay, so let me go back because you had a lot there, but one of the things you said is you have that first exposure to the peanut, and you said it depends a little bit about the environment. And when you say environment, do you mean the bigger environment that the individual is living in and their previous kind of life exposures, or do you mean their internal biology environment and like how they're genetically made up, and which of those two or both are important factors?
It is actually both. So that is in one of our studies. It's called the Sunbeam study, where we are enrolling pregnant moms and then watching the growth of the child until 3 years of age. That is one of the things we're trying to understand. Is it just the immune environment inside, and when is that environment changing, as well as the external environment? What is their diet like? Is there a pet in the home? What kind of medications or exposures have they had? What genetic factors are involved? We have testing for parents, both father and mother, to get a sense of um, what are their risk factors or genetic
Yes.
features that play a role in it. So it really is a combination of all of the above, which makes it such a complicated disease to study.
Yes. But from what you just said, it sounds to me that one of the initial conclusions is that allergies can like kind of run in the family. It can be a genetic, and so if grandma and mom or dad, if they have allergies, it might not be a completely done deal, but it might increase the chances that you have an allergy. Is that
That's
correct?
absolutely right. And the first degree relative that is allergic increases the risk of the child. For instance, when we're evaluating young children in our clinic to suss out, are they allergic, are they not?
Yeah.
What kind of, intervention plans should we undertake? One of the first things we ask is, do you have an older, or we ask the parent, do they have another child who is also food allergic? Is the parent food allergic? Because all of those things kind of play into your decision plan for the individual in front of you.
Yes, and when there is a genetic connection, do they tend to have the same allergies? So, like I have suffered in the past, and I think I talked about it on this show from a shrimp, crab, lobster allergy. Does it mean that my children or my siblings might have that same allergy, or does it just raise the chances that they have some allergy of some kind?
So it is the latter. It is that it raises their risk for having a form of allergy. And this, I know we say allergy for food allergy, but really it could be asthma, eczema, and food allergy, environmental allergies, as well as a condition we see a lot. It's eosinophilic esophagitis, where it's almost like eczema in your esophagus. So all of those fall into this allergic phenotype, and having one or more of any of those conditions can increase your risk for food allergy.
Great. And then the other thing I have to ask you about is has been a theory, and I don't know if it's still the one that drives the field, that part of the problem was that we were keeping our children too clean, that we were worried about like don't let them don't let them hug the cat, don't let them walk on the dirty floor, make sure they eat everything, including things that are not really food but like sand and dirt. Is that still part of the equation?
That, yes, absolutely. As we learn more and we're learning about our environment, we're understanding that microbiome plays a huge role in effective functioning of our immune system. So, as my mentor Kari Nato used to say, really, food allergy or allergy prevention were the 6 Ds. So you got to focus on dry skin, diet, playing out in the dirt, having exposure to dogs or pets that kind of bring in
Yes.
allergies from the outside, vitamin D exposure, so being out in the sun, and then minimizing detergent use, which can also
Huh.
cause barrier function on your skin, dysfunction on your skin.
Well, there will be our future of everything quiz will be, can you recall Tina's and Kari's 6 Ds? Now I know that you've also written and thought about climate change, which is a little bit surprising. But does climate change actually factor into this equation?
Yes. So actually, we were talking about before we started this recording, you were talking about your allergy to flowers and pollen allergy. And what we're finding is in this warming climate where the temperatures are rising and there's increased CO2, what we're seeing is that the pollen seasons are actually getting longer and longer.
Oh,
And with the high CO2 and the high temperature, the allergenicity of the pollen is stronger. So you're getting longer pollen seasons with stronger allergens that are impacting, that are really causing much more severe symptoms, and more individuals are impacted.
I must say, climate change comes up all the time, and it's rarely good news. And even for allergies, it's taking its toll. Thinking about the global, and as climate change is a global phenomenon, are allergies a global phenomenon? Do different cultures have different allergies, or do you see the kind of same types of things across the board?
Yes, it really is a global phenomenon. Our team did a review a few years ago. We were trying to find data from really every continent, and we did find that across the globe, ER visits related to food allergic reactions or anaphylaxis were rising up. More and more individuals are being impacted. In Australia, where they've actually followed entire cohorts in categorizing food allergy, it has been rising despite some early intervention strategies. So it really is a global phenomenon. And in terms of what allergen we see, it really is much more area dependent. For
Huh.
generally, the same allergens pop up everywhere, meaning the peanuts, the tree nuts, shellfish, but kind of the distribution of each of the allergens, there is some variability. For instance, we see a lot of peanut and hazelnut, but in Italy, hazelnut is much more prevalent than peanut, even though both of them are high up there. And it really kind of ties into the processing of the foods, how the child is exposed, and how much of that allergen they have in their environment.
So let me just ask about this. You mentioned these two allergies, the nut allergies and the seafood allergies. Do we have any idea what it is about those two types of food? I know that you can see allergies of anything across the board, but those ones just pop up so much. Do we understand what it is?
That we, and even within those allergens, we see that some of the nuts are more potent, as in they trigger reactions
Yeah,
at
I saw you
much
had a
lower
paper on the
dose.
difference between
Yeah.
cashew and peanut,
Yes.
and I
Yeah.
thought that was amazing. Like, wow, she's really splitting hairs here, but I guess it matters.
It does matter. And, this is anecdotal, but in our outpatient clinic and research clinic, and in research, we are blinded, so we don't always know what they're getting. But if it's a severe reaction and they keep having symptoms, we're like, oh, I bet that was a cashew challenge. And then when we're
Wow.
unblind, more often than not, we are correct. And in our outpatient clinic, where we do a lot of food challenges and oral immunotherapy, the second our team hears cashew, they're on higher alert than usual, just because we between among the allergens we do see some variation in how patients are reacting and at what dose they're reacting.
That's just amazing, and I was so surprised to see the cashews come up because I hadn't been aware of a cashew allergy. Of course, I have been treated for allergies, and it was me and a bunch of little kids who had peanut allergies, and a lot of fun stories there, which I won't go into. But basically, they were very impressed at how much I could breathe because, of course, I was 3 times their size. Even though I'm not such a great breather compared to a 7-year-old, I have a good lung capacity, and so we were all getting very competitive about our ability to blow into the machine. I did want to ask about a thing that has just recently gotten on my radar, and I know that you're a food specialist, but I suspect that you're aware of this syndrome called beta gal, which
Mhm,
has
mhm.
started to pop
Alpha
up,
gal.
and I have a relative actually who has it, and I know it's very debilitating. It manifests as, and this doesn't really capture the whole thing, but as basically like a meat allergy. And I'm wondering if you can just tell me about that and what is known. It seems to have just popped up recently, but maybe that's wrong.
No, no, you are right. Alpha gal syndrome.
Alpha
It's
gal. I'm sorry, not
No,
beta gal.
no, it's almost it starts off. I will preface this with saying we don't see a lot of alpha gal in our area, and being
Okay.
pediatrics focused, I haven't done a lot of work or research in that area.
Yes.
In fact, I don't even really test for it unless I have a really strong suspicion. But certain areas, and we have collaborators who are working on this in Arkansas, and where it's a tick-borne condition that you basically you get sensitized to this protein, and then it cross reacts with different meats, and then
Oh,
when you eat the meat, and this can pop up out of the blue, similar to your shrimp or your shellfish allergy,
yes.
where you are totally fine, and then all of a sudden you start having symptoms
Yes.
and you have anaphylaxis. It happens quickly, and it's just hard to diagnose because it can cross react among different meats, and it there are some studies going on right now that are led by the NIH. It's an area of special interest for the NIH, where they are trying to further categorize this condition. It's hard to test for. It's just very unusual. And you're right, it is popping up more and more.
Yeah, so the family member that I'm thinking of lives in Kansas
Mhm,
and
mhm.
is 30 something, a young mom, and all of a sudden the anaphylaxis, and they kind of narrowed it down that whatever, and an exquisite sensitivity. So we had a family gathering, and she had to stay outside, and she had to ask that none of the meat, even the smell of the meat on the barbecue, she said could have triggered her symptoms. So it was very disabling, and it's having a big effect. And we're going to be talking about treatments because that's, you're an allergist MD, and your whole thing is to try to treat these folks. But I know that that's been a very big challenge for them. So before we go to treatment, I did want to ask about multiple allergies. Sometimes you have a single person, like my main problem was shrimp and seafood, but other people have kind of across the board. And I know you've written a lot about multi-food allergies. Is this the same deal, or do you think these people who suffer from this have special features that makes it kind of different from the people who have single allergies?
Yes, so the majority of patients, maybe not majority, but a lot of the patients we are seeing in our research unit who are coming in for severe treatment or treatment of their severe allergies tend to be multi-allergic.
Okay.
In the literature, up to 45% of food allergic individuals have multi-food allergies. One of the things we are trying to better understand, there's so much unknown about food allergy, is the phenotypic differences between those that are just monoallergic versus multi-food allergic. And at this time, we are not seeing obvious differences between these individuals. Also, we're trying to better understand, children who outgrow their food allergies, right? What is different about them and their immune response versus the kids who don't outgrow their food allergies? So all of these are areas of better research. At this time, from the clinical perspective, when a patient's in front of you, the reason whether it's one food or multiple food comes into play is your shared decision making on how best to treat it. Because if it's multiple foods, it might change your decision making on how to treat it versus just a single food.
Fantastic. This is The Future of Everything. I'm Russ Altman, and we'll have more with Tina Sindher next. Welcome back to The Future of Everything. I'm Russ Altman, and I'm speaking with Tina Sindher from Stanford University. In the last segment, we learned a lot about allergies. The rates are going up, the difference between food allergies and environmental allergies, and the different ways that we can start to understand how allergies form and what we can do to stop them. In this segment, we're going to specifically focus on prevention, diagnosis, and treatment, of course. There's some new drugs that are very exciting. I want to talk about prevention. I don't think about prevention of allergies because usually it's kind of a surprise and like the game's over, we already have it. But I know that you've been doing work on prevention. What could be the strategy for preventing allergies?
Yes, so one of the ways that we are thinking that we can prevent food allergy is early introduction of food and a diversity of food introduction. And this all came about around 2015. So ahead of that time, the American Academy of Pediatrics would recommend that you delay introduction of allergenic foods. So peanut, tree nuts, till beyond 1 year of age. In fact, fish and shellfish were at 3 years of age. So
Wow.
it really was pushing out the introduction. And then the LEAP trial was published out of UK, where they found that children who were sensitized to peanuts, so testing was positive, if they introduced peanut into their diet, they were less likely to develop peanut allergy down the line. So there were two groups, ones who avoided peanut and ones who didn't. And the children who avoided peanut were 5 times more likely to develop peanut allergy later in life.
Wow.
So with that study and then subsequent other studies showing similar findings, the AAP reversed its guidance in 2017 and started recommending early introduction of peanut. And now that has really been expanded across the globe. Different societies and academic committees have put out guidance on early introduction. There is still a lot of, I won't say controversy is the right word, but it's hard to get consensus of which allergens, how often, how early. So there are some continued discussions on the
so it's
exact
possible that
timing.
some things might be best early, some things you might
Right,
want to wait. And so
right.
people are trying to sort that all out, and there's a
Right, trying
lot
to
of different
yep,
foods.
yep.
So
And
that's a
then
lot
how
of different
often, right?
decisions.
Like a lot of times you give a baby a little bite and it's hard to
Right.
keep it in their diet because they might develop taste for something else. So there is a lot of research ongoing in that front. And it really is a global effort trying to find the right balance. So that's one strategy. strategy. Another strategy is through the skin. Other studies have found that when you have dry skin or eczema at a very young age, so maybe from the time you're born, before 2 months of age, if you have moderate to severe eczema, you are at a much higher risk of developing food
Oh,
allergy.
interesting.
And so studies have shown that if you treat that eczema early, it may reduce your risk of food allergy. So one of our studies, it's called the SEAL trial. It's
Seal.
different than the Sunbeam trial.
You have very beautifully named trials, I must say.
We are enrolling babies less than 2 months of age who have dry skin and eczema. And one group is getting standard of care, no treatment. The other group is getting aggressive moisturization along with steroid treatment for their skin. And then we're following to see who develops food allergy and who doesn't, to see if really aggressively treating the skin will lead to a lower incidence of food allergy. And the reason the two of these play a role is there's a hypothesis out there called the dual allergen exposure hypothesis. And essentially what folks are thinking is that you are getting sensitized when the allergen is interacting with your immune system through the skin.
Yes.
And usually the skin provides a beautiful barrier, but in the setting of dry skin and eczema, that barrier doesn't work as well. So the allergens are entering, they're interacting with your immune system in an aberrant way,
Yes.
triggering that. In the beginning, I talked about this allergic milieu and Th2 skewed in immune system. So it's kind of driving that skewed immune system and causing you to develop the allergen-specific antibodies. So the first time you eat peanut, you're already sensitized because you got it through the skin.
Wow, that's exciting. That's exciting. And who would think that the skin of a 2-month-old, which of course we always talk about a baby's bottom and a baby's
Right.
skin, but they're
Yeah.
not always perfectly intact, and that barrier is very important early on.
That's right.
So, well, that leads us very naturally into from prevention to diagnosis. Now,
Yes.
as I've intimated, I have suffered from allergies, and I think twice in my life I've been laying, belly down on a table where they gave me like 60 different pinpricks with had 60 different little samples. I know for one of them, 58 out of 60 were positive. But is that the state of the art, or have we been able to get a little bit better at making these diagnoses?
Oh, I am sad to say that we are still doing that method. That's skin prick testing. And essentially, whatever we suspect you're allergic to, we take that extract and we prick your skin essentially to get your mast cells activated. So if you have allergen-specific antibodies on those mast cells, they react and cause a wheal that looks like a mosquito bite.
Yes.
We have ways of measuring that specific antibodies through IgE testing, but both of these have a 50% false positive rate. So
Oh my goodness. Oh my
they are
goodness.
not great diagnostic features. If they're negative, we feel confident. If they're positive without a clinical history, let's say it's a baby who's never eaten the foods before, we don't know how to interpret it. So the gold standard of treatment is actually food challenges, where we bring you into clinic and feed you the food you're allergic to see at what level you develop a reaction to.
Wow. Yes. And so, and that can be not fun depending on how the reaction goes. And of course, I'm sure people come in very nervous because they've had bad experiences. So just to make sure I understand, when you are doing these pinpricks, this is literally ground up stuff. Like, this is not high-tech bioengineered molecules. I took some peanuts, I mashed them up into like a powder, and maybe put them in some water or oil, and that's what you're injecting. And is there a so there must be standards that somebody makes.
We do use a step above that. We do use standardized product through a company where it follows strict guidance through the FDA. So we are getting very well characterized extracts. So we know exactly how much protein is in there. It is reconstituted in liquid formulation so that it is standardized across the board. But when folks come in with allergies to uncommon things that you don't have extracts too. What you describe is exactly what we do. We call it a fresh prick to prick testing, and we have them bring in the food. We crush it up, add in some glycerin, and then we
I kind of love it. It's kind of like old fashioned medicine, like what they did. And but let me ask you. You talk about the gold standard was an oral challenge, but some people have allergies like hay fever, like to pollens. You're not having them eat the. Is there a gold standard for them?
yeah,
Because you can do the pinprick, but if you're not sure, what is the equivalent of having them swallow some, or do you have them swallow pollen?
no, no. So in research trials, we actually do something called a nasal allergen test,
Oh my
where
goodness!
where we insert small incremental doses of the allergen through the nose. It is not pleasant for
No,
anyone.
no,
In
no,
our
no, no,
clinical
no.
practice, we don't do that. We focus on symptoms, and then with the testing, it helps us guide how to prepare the immunotherapy regimen that we come up with.
Great, great. And then and I didn't want to leave, of course, because there's been a revolution in treatment. So I want to give you some time to tell me and us about what are the frontiers of new treatments and what is kind of coming down the pike that you're excited about.
Oh, yes. It actually has been a very exciting time and when it comes to treatment of food allergies. So prior to 2020, the standard of care was avoidance. If you come into clinic, we diagnose you, we're like, okay, you have food allergy and just don't eat it. Good luck. Here's some epi in case you have a reaction. But really, we had no approved treatment option. So the first medication that was approved is peanut oral immunotherapy, where you take incremental doses of peanut, and it desensitizes you so that over time, if you come across a bite of a cookie, you're not having severe anaphylaxis and ending up in the emergency room.
I
Um,
think it's worth pausing here.
yeah,
This idea of desensitization. So they have a peanut allergy, but if you give them tiny amounts and then like increase it, you can maybe avoid these big reactions and get them to kind of tolerate the peanuts. It's kind of good news. And does it always work? And can you get that initial dose small enough so that it doesn't set off a big reaction?
that is right. We start at a very low dose. So, to put into perspective, let's say a one peanut is approximately 300 milligrams of protein. We start at 3 milligrams of protein, so
Okay.
1/100th. And in
Wow.
our outpatient clinic, if someone were to react at that dose, I just go down even lower. So, you can titrate it to a lower dose where you don't induce severe reactions at that
Okay, I'm
early.
sorry I interrupted, but that's the
Oh no!
desensitization.
I always tell families to think. I don't know if you watch The Princess Bride,
Oh,
but
of course.
it's the poison. The poison in the cups where he's desensitized himself to the poison, which
Yes.
is exactly how.
Iocane powder.
Yeah. So that's exactly oral immunotherapy.
Okay.
Um, and the downside is that you have to dose every day.
Oh,
And if you stop dosing for a few weeks or a few months, you may go right back up to your prior sensitized state. And as children, I don't know if it's ever easy, but when they're little, parents can really be a part of this. But as they get older, preteens, teens, in college, it is very hard to accomplish. And then children and adults come across dosing fatigue when you're having to eat the
right.
same food
Right.
every day. And we're just talking about peanut, but for the multi-allergic kids, that's so many foods that they're having to eat every day. So it's not easy. Kids have reactions. They can still have allergic reactions. So we need better ways, and that's where the next drug, which actually just got approved for food allergy in 2024, is omalizumab. And
That's a
this
mouthful.
that's that's a mouthful. Um, and omalizumab is an IgE blocker, so it's an injection, and you receive it every 2 weeks or every month, depending on your total IgE level and your weight. And it binds to the IgE and takes it out of
And
circulation.
IgE is the molecule that recognizes the
That's right.
thing that you're allergic to.
That's
So
right.
no IgE, no reaction.
That's right. That's right. So it takes it out of circulation. So kids and adults are able to ingest that food in small amounts. There is a threshold level. It's not like you can eat the food as if you're non-food allergic, but they just don't have reactions at a level they would previously have reactions to.
Do they have to keep taking that medication, or is it a one-time or two-time thing?
So, what we found, and that is really what's been an issue in the food allergy therapy, is that your immune system is very robust. And the second you take away whatever the treatment is, your body goes right back to being allergic. So, it'll take 6 months to a year for the full effects of the Xolair to leave your body. And at that point, you may revert back to your allergic state.
Does having the IgE wiped out by the by the mouthful, also known as Xolair, but that's the brand name, and we like to keep things generic. But uh, is it possible that you could then desensitize somebody in the old-fashioned way, and then with regular exposure to the food, they might not need more of the Xolair?
That's exactly right. And these were studies led by Kari Nato in the very beginning, and then followed up on by Dr. Sharon Chintraja, where we actually did, through the NIH and the Consortium of Food Allergy Research, a multi-site study where it was Xolair plus oral immunotherapy, and then the Xolair is taken away, and the food introduction continues to really do what you suggested. The Xolair takes the IgE out of circulation. You get up on all the foods that you're starting to eat in a safe way, and you keep going on that, so you continue the desensitization with the lower risk levels without having to take an injectable for a long period of time.
Great. So I have two questions as we come up to the end of our time. But the first question is, can you can you calibrate me for how exciting Xolair is for somebody who's suffering from allergies? Should they think like, okay, this could really solve my allergies, or is it, or should we temper their expectations and say this will help, but it might not be the full answer? So where are we in terms of the excitement about this new drug?
Oh, so what I tell my patients and my families is that we have yet to come across a one drug that fits all. And there are differences in individuals. So I hesitate to say this
Yeah.
will solve all your
Right.
problems. But I have seen really good results. For instance, I've had, preteen teenagers who've been very successful with OIT. However, when Xolair came about, they started Xolair, and what's great is that he goes to camp without having to worry about
Right.
dosing or travel. And he, told me how he went to an ice cream shop with his friend, which in the past he would never have done.
Huh.
So outside of eating the food, it really improves quality of life and just the psychological burden of having a food allergy. So, and it actually can help because it takes all IgE out of circulation.
Yes.
It can help, not just one allergen, but multi-allergen,
Right. And we were talking about the
food and
multi-food
environment.
allergies.
Yeah.
Great.
So
Great.
this particular child, also avid baseball player, had severe grass allergies.
Oh.
And after Xolair, his symptoms went away for that as well. So it works really well for
Good. So that's a great calibration, that it can be almost like a miracle, but it's not guaranteed, and we have to try, and we'll do our best. The final question I have is just for those people who are not suffering so much from food allergies, but from environmental pollen. I know that you've written about things that they can do at home, simple tasks, and we always love to finish our episodes with kind of take home good knowledge for people. So what would you recommend for somebody who is struggling with seasonal allergies, about things that they can do at home to kind of help manage those allergies?
Oh, yes, absolutely. I think step one for all of this is just knowledge. Knowledge is power. So if you're able to really pinpoint which seasons you have the most symptoms, what has worked, what has not worked, and if you're able to get allergy tested so you know what your panel, what
Yep.
you're allergic to, because one of the things you can do is kind of track pollen reports. It's very easy to access through apps, weather apps. And if you know what you're allergic to, you can track it. And right before it spikes, you can start your allergy medicine. So you're
Good.
you hit the ground running. If you have a lot of outdoor allergens, during that season, keeping your windows closed as best as you can. If you know you are cat or dog allergic, if you're going to visit someone, maybe making sure you're, medicated and well, kind of ready to enter the home. What I tell our pediatric patients is if you've been outside all day and you're grass allergic, come home, rinse off, take off your clothes.
Right, because we learned about the importance of skin earlier.
That's right. So get it off of you, because the longer exposure will trigger symptoms, and keeping your bedroom as clear of these allergens as possible.
Do the so there's been a lot of marketing for air purifiers. What's your sense of their utility in this situation?
The air purifiers, actually, especially now with more and more wildfire-related pollution, we do think kind of monitoring the air quality in your home we do think is beneficial.
Oh, good.
And then keeping a filter really in your bedroom, where you spend a lot of time, can help reduce symptoms. I will say all of these are risk mitigation. They're not going to take away your symptoms altogether.
Right.
So after someone has tried all this, I would say, if these are not working, we can do more for you. Please,
Great.
please go see your
We're
allergist.
going to keep hope alive. Well, thank you so much. Thanks to Tina Sindher. That was the future of allergies. Thank you for listening to The Future of Everything. Don't forget, we have nearly 300 now. It's one of the first times I've said this. Nearly 300 episodes in our back catalog. And they're all available for you to binge listen on the future of almost anything. Please remember to rate and review. We love to get a 5.0 if we deserve it. And we love your comments. Please think about rating and reviewing in whatever app you're listening to right now. In addition, you can connect with me on many social media. I'm on LinkedIn, Threads, Mastodon, and Blue Sky at RB Altman or at Russ B. Altman. You can also follow the School of Engineering at Stanford at Stanford School of Engineering, or more simply, at Stanford ENG.